So hi, everyone. My name is Tom Duvall. I'm the team lead for the Comprehensive ESRD Care Model at CMMI. CMMI is the CMS Innovation Center. We were set up in 2010 to essentially test out new and interesting things in Medicare, Medicaid, and across payers. I have a lovely slide deck. It's not there. That's fine. So the CEC model, you also may have heard it called the ESCO model, too. So that's what I've been helping to run for the past few years. I think starting off, a relevant question for the, that's probably better. A relevant question for the ambassadors here. Do you know if any of you all are in an ESCO? Excellent. Yeah, I think we'd be very, or any sort of beneficiaries in an ESCO there? Okay. Yeah, I think because that's something we're always sort of interested in and interested in talking and working with AAKP on especially. So our challenge and sort of what we try to focus on, you all heard a lot today about the $34 billion that Medicare spends in fee-for-service spending on care for beneficiaries with ESRD. So for this, I focus on this chart a lot. And what this says is that of that $34 billion, about 1/3 of it approximately is accounted for by the dialysis bundle. That's essentially a flat amount of spending where no matter how good a beneficiary's health is, that money is going to be spent. However, the other 2/3 is the non-dialysis part of the spending. It's all the doctor's visits, it's all the hospitalizations, it's everything that comes from the fact that dialysis and kidney failure, I think really just hurts your overall health. And this is the effects of all the hospitalizations and everything else. So the goal of what we had, sort of two key goals here and two key ways to think about the model and our efforts here at CMMI. One is as an extension of what Jesse works on as sort of efforts that CMS has been working on for years about how can we improve the quality of care for dialysis. So that's where we have the quality improvement program, dialysis facility compare, star ratings. The other framework that we look at, though, is in the context of the other CMS coordinated care efforts, especially the ACO models. There's been a big focus on CMS testing out kind of ways providers working together to coordinate care. So what we are testing is essentially, are those programs good enough? Or are the needs of the ESRD population so significant and unique that we really need a whole separate program run by sort of separate CMS staff with the separate providers to coordinate and manage the care for beneficiaries? So that's what we're testing. That it's a key framework for all of this that I really want to emphasize is that this is a test. The ESCO framework is not necessarily sort of the end point for this is what ideal care is going to look like in America in 15 years in the Medicare program. It's seeing what lessons can we learn. And we're 3 years in, so we've already gotten some lessons here. So it's seeing what lessons can we learn and how can we build on that to either put something new into the permanent Medicare program or to build on it with another CMMI demonstration there. So the current status of the model, it started in October 15, currently in performance year 3, so here in 2018. We started with 13 ESCOs, and I'll get to what an ESCO is in a minute, and expanded to 37 now across the country with about 55,000 beneficiaries, so about 10-ish% of all Medicare ESRD beneficiaries. So we work with all the different dialysis companies, so 4 of the non-LDOs there, Rogosin, CDC, Atlantic, and Northwest, and 3 of the LDOs with 24 sites from Fresenius, 6 from DCI, and 3 from DaVita. So this map here shows this. Pretty good national penetration, clearly a focus in the Northeast and the South, less in the West, but in general, pretty good national distribution, which we're pretty excited about, and I think helps to improve the quality of the test here. So a few key principles for model design that we are thinking about in designing and figuring out everything. So one is that the beneficiary care is managed by the ESCO, which is kind of a combination of the dialysis facility, the nephrologist, and the other providers working together. However, it's also within the context of Medicare fee-for-service, so beneficiaries can still go see any provider who they want. This is not a managed care plan. This is sort of overlaying and seeing how well providers can manage care within the confines of the fee-for-service system. Another big principle is that ESCOs are held accountable for all Medicare Part A and B costs, including those outside the dialysis facility. But with that greater accountability and being accountable for the cost and quality of care, they get some new tools to manage care. So some waivers of the Stark and anti-kickback rules, allowing the dialysis company to fund greater care coordination and IT infrastructure, as well as the ability to provide greater transportation and nutritional services to beneficiaries. So the model is based on the idea that nephrologists are the key physicians managing the care for the beneficiaries. So the ESCOs are required to include nephrologists, and to help incentivize their role, nephrologists take on individual downside risk. There's approximately 1,100 nephrologists participating in the CEC model, which is about 15% of all nephrologists across the country. So pretty good penetration there. And for those who know about QPP, the CEC model qualifies as an advanced APM, so nephrologists can get a bonus by participating in this model here. So the financial model is based on the idea of comparing what we expect their aligned beneficiaries' expenditures to be versus what they actually are. So the way we figure that out is we kind of figure out who all of the beneficiaries were who visited the relevant ESCO dialysis facilities during the year. Then we compare what their actual expenditures were versus what the historical expenditures were for the beneficiaries who visited the dialysis facilities in past years. We trend that number, risk adjust that forward, compare the numbers, and see ultimately if the ESCOs ended up saving money. If they do, we share some of that back through shared savings. If they don't, ESCOs will likely have to pay money back to CMS for shared losses there. We also adjust it based off of their performance on an array of quality measures that we have, with the goal of ensuring that any financial savings that do occur don't come at the expense of quality of care. So PY1 results were pretty positive. Overall, it was about a 5% reduction in spending relative to benchmarks. Each ESCO had savings. Quality results we didn't fully have, but we'll get more of those for year 2. We're currently calculating our results for year 2, with the goal of that being posted at some point in the next few months. We also had an independent evaluation conducted that showed the results. So it showed a statistically significant reduction in Medicare spending. The two biggest drivers of it, what this shows is that with the extra incentive, the biggest drivers in reduction of spending by far were hospitalizations and post-acute care spending. That's where we saw kind of the earliest impact. The biggest focuses were on ensuring beneficiaries actually had all of their relevant dialysis treatments, and as well as sort of improving discharge planning with the real goal of keeping people out of the hospital. The effects of this were that CEC beneficiaries were 6% less likely to be hospitalized than the comparison group and 8% less likely to have a catheter. So I think those are good outcomes that we were happy about, as well as an improvement in quality of life on the physical component score of the KDQOL survey. So items for the future here, it already doubled in size. So it went from 13 to 37 ESCOs from year 1 to 2, and ESCOs added more providers for year 3 that we're in right now, 2018. So the model goes until the end of 2020. So we have 2+ years left, and our goal is to ultimately build on the lessons of the model for the future of ESRD and CKD care. So part of what we've seen, because it's been everywhere, is that there's some pretty broad interest in sort of how to build on the lessons of the CEC model, and I think in general kind of coordinated kidney care. We've obviously seen the proposals in Congress and PTAC from a lot of different stakeholders and from our model participants around kind of what the future of ESRD coordinated care looks like. So the model ends at the end of 2020, and we received a lot of inquiries as to what will happen next. So I think ultimately we don't know. You know, there's a lot of decisions to be made by a lot of people, a lot higher than any of us here in the room. But ultimately, I think it's based around a lot of these few questions that we have a few answers for, but I think also are seeking answers from the broader stakeholder community here about how we can learn from what we did include in the model, as well as some areas that we didn't really focus on in the model. So what are the lessons that we've learned from the existing model? How can we explicitly promote greater usage of home dialysis? That's not something that's in the model right now, nor that we have seen any statistically significant increase on. How can CMS incentivize better care before a beneficiary reaches ESRD? I think we all know that there's greater interventions before a beneficiary hits ESRD. How do we set up a model to encourage more interventions before we hit that stage? How can CMS incentivize more beneficiaries receiving transplants? What are the main barriers in the transplant process? I know that CMS recently issued a proposed rule in the burden reduction rule, easing the way that transplant centers are evaluated and removing a barrier that transplant centers have complained about for years, claiming that stymied them performing more transplants. Hopefully that will, the waiting list will evaporate in a year or two. That'd be great. But hopefully at least that will lead to more transplants, which is, I think, the ultimate goal of this idea. And then sort of finally, even if once we come up with what all the right policy ideas are, what's the best mechanism to enact these proposed policies? Ultimately, we don't know. Ultimately, this is going to have to come really from all of you, sort of both the folks here in the room, the folks here who have sort of the lived experience to figure out how do we best craft the incentives to create the best possible care for beneficiaries and I think really save the Medicare program some money. So that's our overall goals and our overall thinking. So I think we'd sort of love to hear from everybody about that and about how we can best move forward.